Well, good evening, ladies and gentlemen. I'm Colin Wilson. I'm President of the Institute and Faculty of Actuaries. It's my great pleasure to welcome you to this evening's lecture. I know some people have some difficulty getting here, but I am starting on time because I'm delighted to be joined by a number of people on our live stream, as well as those in the theatre here. Tonight's evening is in two parts. The first part is honouring excellence amongst our members. David Martin was awarded the Finlayson Medal, actually at our awards dinner last month. But I'm going to give it to him again this evening, and this provides an opportunity for him to say a few words. And the main part of this evening is our spring lecture, which I'm delighted that Dame Sally Davies will be delivering. Before we start, I would just like to remind you of a couple of housekeeping rules. Please do, as always, ensure your mobile phone is on silent this evening. And if the fire alarm sounds, there is no planned test, so please leave by the nearest fire exit. Staff will be on hand to help you with that. There will be a question and answer session after the presentation. And so during the lecture, you can submit questions or comments at any time via Twitter. And the hashtag is #IFOA lecture. It shouldn't be too hard to remember. When we come to the question and answer session, for those in the room, please do wait for the microphone to ensure that those who are viewing on the live stream can hear the question. And I should say that this evening is also being filmed as well as live streamed, so it can be made available afterwards to our members and others on the website. So please don't let that deter you from asking questions. And if you don't want to appear on the video itself, please just let a member of the events team know. The autumn and spring lectures which we organise are part of the Institute and Faculty's commitment to promoting thought leadership and advancing actuarial science. They're intended to be useful resources for members and non-members alike, and on subjects of relevance not only to actuaries, but also those outside our profession. And another example of our commitment to thought leadership that I would like to take this opportunity to promote is the webinar series which our Actuarial Research Centre is running over May and June. These are showcasing some of the large research programs which we are sponsoring at the moment, which are addressing some of the biggest current challenges in actuarial science, whether that's from mortality modelling to the use of big data. Details can be found on the events section of the IFOA's website, and I should say they are free, and each one is being run twice to accommodate different time zones around the world. Another strand of our commitment to advancing actuarial science is the prizes that we award. As I've already mentioned, we were delighted to award the prestigious Finlayson Medal to David Martin last month. This was in recognition of his service to the actuarial profession over many years, particularly in professional regulation and international engagement. And I would just like to give you a few highlights of that. David served as a member of the Faculty Council from 1995 to 2002, and again from 2008 to 2010, including as Faculty Vice President for the last 2 years then. And he was then leader of the Scottish Board from 2011 to 2013, and therefore served on the IFOA's Management Board. And over his career, he's contributed to an understanding of and found solutions to many of the difficult pensions issues of the day. And throughout his career demonstrated his commitment to the actuarial profession both in the UK and globally. In particular, he's promoted the importance of professionalism and professional standards. He served on the Professionalism Committee of the International Actuarial Association since 2004, including as chairman since 2014, and has also represented the Faculty of Actuaries and then the IFOA on the IAA Accreditation Committee from 2007 to 2016. On the European level, he's currently chair of the Standards, Freedoms and Professionalism Committee of the Actuarial Association of Europe. David is the author of a number of papers and presentations to conferences and international congresses, particularly on matters relating to professional regulation. And as chairman of the Professional Affairs Compliance Committee, he was the lead author of papers on monitoring compliance with professional guidance presented to the profession in 1999 and 2000. So just a few of the many things which David has done for us, and therefore we are delighted, as I say, to award him this medal. David, I would like to invite you up onto the stage and then to say a few words.
Thank you, Colin. Do you, like me, ever spend a moment looking at the unopened envelopes when the post arrives in the morning? A few weeks ago, an envelope arrived with the Institute and Faculty stamp on the front. My mind began to race. Haven't I paid my subscription? Have I missed the CPD deadline? But it was with a mixture of relief, surprise, and humility that I realized I had been granted this honor. The feeling of humility was deepened even further when I looked at the list of eminent recipients that had preceded me, and also the story of the Scottish civil servant who was the first Institute president, Ian Finlayson himself. I'm proud and pleased to find that the Council think my efforts on behalf of the profession over the years have merited this. So thank you very much. It's made me look backwards over the road I've come and to think of all the many people who've helped me along that way. Too many to mention tonight, except for two that I would mention, both deceased actuaries, both past presidents of the faculty, Douglas McKinnon and Maxwell Thornton. My involvement with the profession has been in three different areas: pensions, regulation, and international. The first one came very early, when I was still at the University of Glasgow. In the summertime, I worked with Scottish Amicable in Stirling. They weren't recruiting when I graduated, so I started work with Standard Life, again in defined benefit pensions, then very much in demand. I qualified in 1980, had recently been married to my wonderful wife Elizabeth, who supported me throughout my career and is here tonight. I was attracted south from Edinburgh to Croydon to an annual salary of £10,000, a 30% increase, and an extra digit on the end. I worked for a company called QB Wood, part of Noble Lands, set up to permit the provision of actuarial advice under the bizarre rules that applied then. It was a chance to meet clients face to face, something not possible in my insurance company role. And it was part of the job that I really enjoyed enormously throughout my career. I'm retired now from consulting, and I find myself as a client of actuaries, which is rather fun. 2 years after qualifying, I moved to Watford and was actuary to over 100 defined benefit pension schemes, and I had a staff of 1.5 actuarial students. A bit scary in retrospect, but it plunged me into the deep end of actuarial work. It was a time of double-digit gilt yields and clients querying how actuaries could be impossibly ultra-cautious by using a discount rate of 9%. Following takeovers by Sedgwick and Marsh McLennan, a good part of my life, in all senses of the word, was with Mercer in Watford, Windsor and London. As a fellow of the faculty, I was always impressed by Bacon's words that were under the Institute coat of arms, saying, "I hold every man a debtor to his profession." I mentioned to a senior colleague in the 1990s that I was prepared to volunteer for the profession, and I was soon invited to join the Faculty Council. Asked which boards I wanted to join in 1995, these were jointly run by the Institute and the faculty. I chose the Pensions Board and the Professional Affairs Board, which with 2 name changes has become the Regulation Board of today. I sat on that board for 19 years, including 2 as chair. I chose it because it interested me, and it involved me with all areas of actuarial work, and with many different actuaries. One area that stands out around the turn of the century, already mentioned by Colin, that makes me sound very ancient, was the topic of monitoring compliance with professionals and professional guidance. The working group that I chaired presented a couple of papers in the year 2000. It involved me in meeting many people with different ideas, including discussing these issues, including the concept of peer review with many actuaries, including those leading life assurance and consulting organisations in London and Edinburgh. To a man, and yes, Fiona, they were all men, they rejected the idea out of hand, outrageous and too expensive. The topics we covered were internal firm reviews, external practice review, and a review team appointed by the profession. There was a three-horse race among Lloyd's General Insurance Actuaries, life insurance actuaries, and pensions actuaries as the first to introduce peer review. The Pensions Board, after a very slow start, crossed the winning line first. Now, of course, consideration of peer review is in APSX 1 and 2, and so applies to all our actuaries. You might also recognise the beginnings of the current QAS scheme in the practice review ideas that we pioneered. I'm no longer involved in IFOA regulation, but the experience I gained there informs my current roles, including that at the pensions regulator. I take pride in having been the leader of the Scottish Board following the merger of the Institute and Faculty in 2010. That board received a settlement, a sum of money to be used and set aside for use as that board intended. And the main idea that emerged from those discussions was the Actuarial Research Centre. We heard about it tonight. It was launched in 2012 as a joint project with the Scottish Financial Risk Academy and co-sponsors PhD students in actuarial research with Heriot-Watt University and corporate sponsors. But it's grown in the 5 intervening years to become the IFOA's network of actuarial research around the world, which is fitting because the IFOA has an international base of members, more than half of whom are outside the UK. The Scottish Board also began leading projects in maths, education for children, and interactive CPD sessions for Scottish actuaries. And I'm pleased to have been involved with dedicated colleagues at the launch of all those 3. The international nature of the IFOA just referred to means it's so important for it to pull its weight in the international actuarial scene. With recent political developments, the word globalization seems to have taken on negative connotations. But we're a small profession worldwide, and it makes perfect sense to me that we should all work with each other where we can. Chairing those professional committees that Colin was kind enough to mention for the worldwide IAA and European AAE has given me the chance to see how this can work. The word model in the English language conjures up all sorts of pictures, perhaps toy engines or the svelte blonde Swedish version, perhaps of both genders, but more soberly, perhaps, in actuarial circles, is a high target to aim at in actuarial standards, model standards, set up for standard-setting bodies like national associations or bodies like, in the UK, the FRC, along with the IFOA. So they can consider writing standards of their own. The objective is to nudge the actuaries worldwide towards convergence. Where possible, actuarial work will be carried out in a similar way around the world. These bodies, as well as having meetings twice a year around the world, have a lighter side as well. One of the earliest ones I attended was in Washington, D.C. There was a dinner held for the conference in George Washington's house at Mount Vernon on the Potomac River. This was a long time ago. In those days, the dinners were black tie affairs, and they're much less formal now. Representing the faculty, as I then was, I wore full Highland evening dress. I was greeted in one of the rooms on our pre-dinner tour by the great man himself, or a convincing actor in the role. He challenged me straight away, reminding the party that his troops had faced kilted opposition in the War of Independence. So international harmony perhaps took a step backwards at that point. At a time when the UK financial world is considering how to adapt, how it's going to deal with its new role in Europe, I'd just like to say how important I think our role in the AAE, as well as the IAA, will become. Supranational bodies like the World Bank, the International Association of Insurance Supervisors, to name just 2 of the global organizations, listens to the IAA and rarely to national associations. Similarly, in Europe, the European organizations like the Commission and the EIOPA will speak readily with the AAE. Our UK regulators are losing their seats at European tables, but our 6,000 IFOA fellows working in Europe outside the UK and our actuaries here who are continuing to conduct business in EU countries will be affected by decisions made by them. And through membership of the AAE, we can continue to have influence and be kept in the loop. It seems very clear to me, the more closely we work together, whether it's Scottish and English-based actuaries or those in Europe or beyond, the more we work together, the better perceived our profession has become. And with that comes the influence our profession needs to bring to society worldwide. So I'd like to conclude by once again expressing my thanks for this great honour that you've bestowed upon me, and I look forward to continuing supporting the profession in the future. Thank you.
David, thank you very much for sharing your thoughts with us, and thank you once again for all your service to the actuarial profession. I'd like now to move to this evening's main event, and I'm delighted to introduce Professor Dame Sally Davies. In her lecture this evening, she will be sharing her thoughts on antimicrobial resistance and the impact this has on economics and society. I do have a few words of introduction to say here, because I think Sally's experience, as you'll see, is very relevant to what we are here to talk about. She is Chief Medical Officer for England, qualified as a medical doctor, but also obviously vast experience in public health, advising governments on health and social care issues. So we are very pleased that she has consented to join us here this evening. Before becoming Chief Medical Officer, she held responsibility for research and development and was the Chief Scientific Advisor for the Department of Health. She provides professional leadership for directors of public health and was actively involved in NHS R&D from its establishment and founded the National Institute for Health Research. She also sits on the World Health Organization Executive Board and, as I say, advises many governments on health and policy. In 2011, Dame Sally published the Chief Medical Officer's annual report on infectious diseases, and that focused and brought light really on the increasing threat of antimicrobial resistance, or AMR, calling for national and international action to address the key areas of stewardship, monitoring and surveillance, and of course antibiotic development. Since then, she's continued to advocate globally on AMR and spoken at many events around the world. And I know, Dame Sally, you'll also be playing a leading role in the new UN Interagency Coordination Group for Antimicrobial Resistance. The first meeting, I understand, will be held next month, and that's going to be responsible for reporting back to the UN General Assembly in September 2018 on the progress that has been made and next steps. Dame Sally received her DBE in 2009, was elected Fellow of the Royal Society in 2014, and a member of the National Academy of Medicine in the USA in 2015. Please join me in welcoming Dame Sally Davies to deliver the 2017 Spring Lecture.
Thank you very much, President. I wish you can see. I was worrying you couldn't see the slides. So I'm going to talk about antimicrobial resistance. Some people talk about drug-resistant infections. And why is it appropriate for you as actuaries? Well, it's not too bad a problem at the moment. We calculate probably only about 5,000 people a year die in England of drug-resistant infections. But across the world, it's much worse. And if we don't take action, it's going to be very much worse. And if you want to model it, I can't tell you who's going to catch the infection that's resistant to drugs. We have no markers for those who not respond to drugs because that sits with the bug. So I want you to imagine a world in which actually modern medicine doesn't work because a caesarean section generally has some antibiotics to protect the mother. Hip replacements, big operations, usually the patients are protected by antibiotics. But think more deeply about cancer patients. I can imagine a day, if we don't get this right, where I go to the doctor who says, well, Sally, I can give you a treatment and it might well cure you, but you're sure as hell going to get an infection and I may not have the antibiotic. I might choose my bucket list and palliation. So put that beside the impact it could have on our food chain, a shortage of pork and chicken because of uncontrollable infections, for instance. And you'll think this is a dystopian future. But what I want to show you is how this big story is beginning to unfold. Infectious diseases are fighting the treatments we have, and so we have to do something about it. And I hadn't understood this fully until I did my annual report 4 years ago, and then I did clock it. So I'm going to talk briefly about antimicrobial resistance, AMR, infections that are resistant to drugs, whichever way you want to call it, a bit about the complexity, because every time I lift up a stone, I find another complexity. I found one only this week that I hadn't uncovered in the last 4 years. I'll mention how we misuse antibiotics, probably every one of us in this room, let alone across the world, the current impact, look at the future impact, and then talk a bit about what we are doing nationally and globally to try and make this a problem that does not kill more people. So let me start with what antimicrobial resistance is. Drug-resistant infections, superbugs not responding to drugs, and clearly it's a natural phenomenon. I find a lot of the public, when we talk about this, think it is they that develop the resistance, and therefore they need to take more precautions and have more antibiotics, rather than understanding it's the bacteria. And it is actually a quite Darwinian, natural selection issue, that if you have a bacteria and it gets one of the routine changes in its genes, a mutation, that gives it an advantage in the presence of a drug, then it will multiply. And what you have to remember is that the generation time for one common bug, E. coli, is 20 minutes. So one bug getting that selection advantage multiplies awfully quickly. Now, if it was just that, it wouldn't be too bad. It would be a problem, but not too bad. But these bugs are very clever. So I'm going to talk mainly about bacteria. But clearly, you can get resistance in viruses. Indeed, 7% of HIV viruses are resistant now to first-line drugs. Resistance of fungi is getting increasingly common. Malaria, a big problem of resistance in that hotspot Burma, Indochina, Vietnam area that is spreading. This is a problem for all infections, and it's the same natural selection, but I'm focusing particularly, because it's acute and killing people, on bacteria, and look at what they do. They can not just pass it to their children, they can actually pass little circles of DNA with the resistant gene from one bug to another. It's called conjugation. They can go hunting in their environment and find a gene that gives them resistance, ingest it, take it in, it protects them, they pass it on to their progeny. That's transformation. And actually, you can get genetic material transferred by these infective organisms called plasmids, which are a kind of virus that attack bacteria. So if you think about it, that's 3 ways where they can catch resistance from another bug or their environment and then pass it on to their cousins, their sisters, their aunts, uncles, and all of them, as they have more, will have that resistance. So you can see how horrible this is. And then if you think about these 3 different methods, you'll understand it's really easy to pass it from one type of bacteria to another type of bacteria. That happens a lot in our guts. And as we are getting our understanding of this to be better and better, we're also understanding more and more about how important healthy bacteria are to our health. We have more bacterial cells in us and on us than we have human cells. And when they're disturbed, we can become ill. It's called the microbiome, and it's a new science where we're learning a lot. And we partially inherit our microbiome from our mothers. We acquire it. So I want to mention a bit about this issue of complexity and how every time I lift a stone, I discovered more. So when I started on this journey 4 years ago and discovered that it had got much worse than it had been when I looked after children with leukemia or people with sickle cell disease, and I'll come back to why it's got much worse, I thought this was a problem of humans. But of course it isn't. It stretches to aquaculture, that's fish farming. So do you know what they do in fish farming around the world? They tip antibiotics into the fish farms in order to protect them from infection. And then that's washed out as they clean the fish pens. I'm pleased to tell you, not in Scotland for salmon and trout, so your Scottish salmon and trout are fine, or in Scandinavia, where they're vaccinated, individual vaccinations with a mixture of 3 vaccines. But you can see how, with normal aquaculture, the antibiotics leach into the water and around everywhere, sewage, and then get onto things, and they therefore can reach wildlife. And here we are, surrounded by bacteria, and we're exposing them to antibiotics that drive the development of resistance, and once resistance develops, drives the proliferation and expansion of that clone. Happens with pets, as companion animals are called, happens with food animals, and I'll come back to the food animals, but over 70% of antibiotics across the world go into food animals because it gives them growth promotion, it's a cheap way of making them grow, and it's cheaper than good hygiene and sanitation. And then it gets into the food chain, and here's even more complexity for you. So it really is a very complex issue, and I think that's one of the reasons that people, it's not the only reason, hadn't started to do enough about it. And actually, it isn't necessarily from the eating animals raised using antibiotics that it always affects us, but as well, the antibiotics eaten by animals, including us, at least 70%, passes straight through and out into the urine. So there was a study in China of primary school children who'd not had antibiotics in the preceding 3 months. They found 21 different antibiotic residues in their urine. Those children were being exposed through the water they drank, the water they washed in and swam in, and the food they ate. The average growing pig in China excretes 175 milligrams of antibiotics every day. That's the equivalent of an adult antibiotic pill a day, just going out like that. So we're damaging our environment. And this, I think, is very, very worrying. I should have done that as we went. Let me show you a bit more of that. So in 2014, researchers from Newcastle University and the Indian Institute of Technology tested water from the Ganges, found levels of a resistant bacteria gene, which we call NDM1 because naturally the Indians don't like the original name of New Delhi metallobeta-lactamase 1. And that makes bacteria resistant to carbapenems, one of our last resorts, a really strong class of antibiotics. And they found the levels of this NDM1 resistant bacteria 20 times higher in the water of the Ganges during the pilgrimage season than at other times. But I don't want you to go home feeling comfortable about this. There's sewage in their water from overloaded waste handling systems, but actually it happens in Britain too. So this is a story from the University of Exeter, who in 2014 found, as it says, that 6.3 million water sports sessions in the preceding year had been exposed and probably ingested at least one type of resistant bacteria. And indeed, when you start to look at the overflows of discharging raw human sewage into rivers and seas of this country, there were 31,000 overflows last year, putting bugs into the sea, the rivers and sea, and many of those will have resistance. So what have we done to make this worse? It should come to us as no surprise when Alexander Fleming went to collect his Nobel Prize. He said, "The time may come when penicillin can be bought by anyone in the shops. Then there is the danger that the ignorant man may easily underdose himself and by exposing his microbes to non-lethal quantities of the drug, make them resistant." He recognized the problem, but we have used antibiotics far too easily, far inappropriately, not just in healthcare, but in agriculture, as I've mentioned, crops, livestock across society. I'm told that one antibiotic, tetracycline, is put into the paint of some warships because it stops barnacles sticking. So you can see why people do it, but it's one of those areas where we hadn't recognized the long-term effects. And there is a direct correlation between antibiotic use and resistance. And here I can show you on the vertical axis, penicillin non-susceptible streptococcus, and on the other side, the horizontal axis, outpatient use of penicillin, and you can see a very direct relationship for EU countries. I'm pleased to say that we are quite low down. We're not too bad. It's very interesting that you'll see it in some maps in a bit. The further north you go in Europe, the less of a problem this is, because the better controlled the use in humans and animals is. So, in many of these countries, you will know the problems they face, Spain and France. And if you look at total antibiotic consumption per capita, as I show you here, you can see Australia, America, and Europe are the hotspots. Actually, Australia's really worrying, and I've just been down in Australia for a couple of weeks at some conferences on antimicrobial resistance, and it was very interesting that they didn't have a big push on it, and their levels of resistant organisms are much higher than ours. So maybe as actuaries, as you give advice, you have to look at our maps to see where this is worst. These maps come from all sorts of places. In Europe, the best maps of resistance are produced by the ECDC, European Centre for Disease Control, and they're all on the webs, and it's really fascinating. But what you see in this world map as well is how the developing countries are expanding their use. We may be the largest consumers, but it is a sign of development and improved health services that other countries are starting to use them. Fine, and so they must. But actually, I also want to highlight that at the moment, more people die of lack of access to antibiotics than die of resistance. What I'm trying to prevent is us flipping from more dying of resistance. And it's a long haul, and you'll see why, because we don't have the new drugs, and new drugs take 20 years to produce. And I also want to highlight, as I show you this, that antibiotics are not a good substitute for public health. Diarrhea claims 1.1 million lives a year across the globe and is the second most important cause of death in children. 60% of those deaths could be avoided by access to safe water and sanitation. And actually, we can reduce our use of antibiotics, all of us, let alone across the world, if we use good hygiene, hand washing, sanitation. So clearly drugs are not good enough on their own. We need investment and education, good hygiene and sanitation. And I didn't bring today, but I could have shown you some of the impact of President Modi's lavatories across the country. Wonderful move, millions being built. But in many villages, the men have taken the lavatories and used them as storage because they don't mind going in the fields. And it's very worrying. Now, if you want to control this, then surely you reduce prescriptions. But what you see here is, as Alexander Fleming said in his acceptance speech, penicillin can be bought in shops. And where it's purple and red, it's bad. And many of you may have done like me and gone into pharmacists in Italy, in France and Spain and just bought them over the counter. But actually, it's even worse in bits of the world. If you go to Bangladesh and Nigeria, for example, you buy them at a kiosk in a market. And if you're poor, which most are, first of all, you won't have a prescription, so you don't know whether you're getting the right one, and often in India, you can buy injectable ones in that way. Secondly, you probably can't buy a whole course. You can probably buy a day or two. So you are going to stimulate the development of resistance. So we have a problem. And it's getting worse in Britain too, because hard as the regulatory agency, the MHRA, works, the internet is still selling antibiotics through the post in this country. And there are regular prosecutions between the MHRA and the police of internet pharmacies. But of course, another reason for people overusing antibiotics and driving resistance is actually using them when they're not needed. So put up your hands if you think you've had an antibiotic when actually it was a virus, a cold or a flu, and you probably didn't need it. Yes. Gosh, actuaries are much better trained than most of the population, or much shyer. Or you don't care, in which case, hard luck when you get to die of a drug-resistant infection, you know. I hope you took out your insurance or your pension plan or whatever it is we're supposed to do before you did it. Critical illness. You could do all of it. But please take antibiotics when you need them and not when you don't. They don't work with viruses, coughs, colds, flus, things like that. But the pressure many of our public put on our GPs is amazing. I think it's very difficult for GPs. And we manage to prescribe at least 10 million unnecessary prescriptions a year in England alone. And it is gettable on top of, but it needs a lot of public education and work. We've done some behavioural work with GPs, and steadily the use of antibiotics by our GPs is going down. But it's not easy, because we have to take the public with us. I've mentioned livestock, but antibiotics are routinely used in two-thirds of antibiotics, sorry, it's the other way around, are used routinely in livestock to get growth promotion. I'm happy to tell you that since 2006 this has been illegal in the EU, and actually it's being phased out in the States. In the EU, so for us, we made it illegal because we felt it was wrong to overuse antibiotics. In the States, a lot of this is actually consumer pull. Then many restaurants now advertise, we use antibiotic-free chickens, antibiotic-free pork, and it is seen as an important consumer issue. So it's beginning to change, but as incomes rise across the world, the demand for meat is rising, and if antibiotics give you this growth promotion, you can see why people go on using them. What we need are new technologies to increase growth, but without the antibiotics. And there are technologies being worked on, but they'll have to be cheap, because one of the reasons people use antibiotics is, in general, they're really cheap. I will come back to that. So before I move on further, I do want to just address this access versus excess issues, because as we try and solve this problem globally, I don't want us to get into the position that climate change has got to, where two things have happened. One, people dispute the science. I have yet to understand why. The second is the South says, you, the North, did it. You're now saying we can't have that development opportunity. Why should we do that? And they see it as the North bashing the South. So I think in solving this problem of AMR, drug-resistant infections, it's incumbent on us to try and solve the access issues as well, so that more are used appropriately and there are fewer deaths because people didn't get the antibiotics they wanted. And here you can see that 40% of deaths in low-income countries are from treatable infectious diseases. And then this study, which Bill Gates quoted at me when I said he needed to do something in this area, and they're just developing their strategy at the moment. He said, but you know, we did this study, and we showed if we gave antibiotics to all the children in Africa, we'd save 75% of the children who would otherwise have died. It's very powerful, isn't it? We don't want those children to die. How do we balance all of that and get it right? And we're going to have to do it by using rapid diagnostics and new drugs and all sorts of things. But I told you earlier, I lifted a stone only this week and found yet another problem. That a lot of the cheap old antibiotics, which are off patent, so they're called generics, are not easily available. Actually, in this country, let alone in Africa. So what I had thought was a problem of logistics and cost in some of these African countries is compounded by, and they're only selling more expensive ones rather than the ones that are really dirt cheap. And they have a much smaller selection of antibiotics. So clearly, we're going to have to bottom out what is available, what isn't, and how do we get them manufactured and distributed in order to be fair. And the final area in this that we're going to have to do some work on, and it's really knotty, is counterfeit and substandard antibiotics. I've already mentioned the internet, and clearly that's a place where counterfeit and falsified antibiotics are very common. This is an issue. The WHO estimates 50% of drugs sold on the internet are counterfeit. I was told recently about a country that thought it had got resistance to the antimalarial drugs it had bulk bought. Then someone thought to check the drug. It was chalk. They did not have resistance. People were dying because some profiteer had sold them chalk for that country. in developing countries, counterfeit drugs account for between 10 and 30% of all drugs sold, but can, in some bits of Asia and Africa, be at the 50 to 60% of drugs tested. So it really is a big worry, because if you get a sugar pill or a chalk pill, you're not going to get better. And if it's just got a bit of the antibiotic, you're more likely to actually drive resistance. So let's just have a bit of a look at the current position where we are. And I want to tell you about the last drug. So this is colistin. Colistin's really a nasty drug. It was developed in the 40s, and when it came into use, we decided not to use it in humans because it knocks off your kidneys and your liver. So we put it on the side, and it was used in animals. Unfortunately, because of other resistance, we're now having to use colistin in humans, knocking off their kidneys and livers en route, hoping you can kill the bug before you've done that damage. But unfortunately, because of inappropriate use of it, mainly in animals, but also probably in humans, in 2015, a Welsh group working with Chinese scientists discovered resistant E. coli in the guts of pigs. It was called MCR1, that gave resistance to colistin, and that was in China. Now, they predicted it would spread globally, and what we don't know is whether what I'm about to show you is global spread after this finding in China, or whether it was there and once you started testing, you looked at it. But it was found in Denmark, then in the UK, and then in the US, and by the end of June 2016, it was in 32 countries, and there are plenty more that we don't know about. So resistance is low to colistin. It's not that common, but it's out there, and it surely will spread. It'll get worse, and if we get it combining with another resistance gene, then we will be at the end of a post-antibiotic era. So what would that look like? You, as actuaries, may well be aware that the WHO calls us the TB capital of Europe. 8 of our London boroughs exceeding their high incidence threshold of 40 cases of TB per 100,000. Well, in 2014, 126 of those cases were resistant to at least the first-line drug. And you probably thought it had been eradicated. It's a very unpleasant illness. This is a lung. That circle is round a cavity in the lung caused by TB, and people cough up the gunk from there and bleed. So when I was a young doctor, I sat by the bedside of a man for a night as he bled to death from one of those cavities. There was nothing we could do. If you have multi-drug resistance, you have to take quite a lot of tablets, which amounts to 19 pills a day for 2 years. So if you get multi-drug resistance, you're going to have to take over 14,000 pills to get better. How many people can afford 40,000 pills? How many people will adhere to 14,000 pills? It's very worrying. So let's take another issue, gonorrhea. Really horrid disease. Can give you pain urinating, it can give you arthritis, neonatal eye problems, which can lead to blindness. And until recently, this was treated with a single pill. Since 2011, we've had to use 2 to treat cases in England, because we've had an outbreak of gonorrhea that's highly resistant to an important drug, azithromycin. So, what happens when we get resistance to that? We're going to have to go to the old-fashioned treatments, which sound really nasty. So you could do urethral irrigation, and they used to put mercury or iodine into the bladder to wash out the germs. Look at that. Fancy putting that up yourself. You could try getting into the hot box and being heated to 43 degrees in the hope that would kill off the disease. So what we've got is resistance levels rising, and by our behaviours we're making this worse. And the message is very like climate change. This is a generational transfer. We will probably be all right, but our grandchildren won't unless we take action. And at a conservative estimate, antimicrobial resistance is claiming at least 25,000 lives in Europe every year. That's about the same as a Boeing 747 crashing each week. Golly, if it was a Boeing each week, we'd hear about it. The problem, which is why you don't hear about it, is it doesn't have a face. Because the death certificate doesn't say drug-resistant infection or AMR. It says died of pneumonia or died of E. coli infection. And it's because there isn't a code for it in the WHO codes. I can tell you, I've been pushing very hard with the Office of National Statistics and Public Health England, being sent to meetings around the world to try and get a code for it. So it's very difficult to get the numbers. But at least this number die in the States every year too. So this is already a real cause of disease. So when I kind of came across all of this back in 2013, I thought we should do something about it. And I persuaded our then Prime Minister that what we should do was use the model of climate change where the debate around the world changed when Lord Stern looked at climate change through an economics lens. So Prime Minister Cameron commissioned Jim O'Neill, now Lord Jim O'Neill. Clearly, if you want to go into the House of Lords, you have to be an economist and do an important review for a government, our government, to review it. Jim used to be the chief economist of Goldman Sachs. And what he found was that at the moment, on a conservative estimate, there are probably, and it's here, around 700,000 people dying a year of drug-resistant infections. I can tell you that the work from India suggests that at least 60,000 babies die every year of drug-resistant infections. So 700,000 is a death every 45 seconds around the world. And clearly, if we don't act, this is only going to get worse. And they did some work, the O'Neill review team, and what they showed is that by 2050, if we don't take action, we will have 10 million deaths a year. More deaths of drug-resistant infections than of cancer. And actually quite a lot of the cancer deaths and the diabetes deaths will be down to drug-resistant infections. And so that's going to cost rather a lot too, somewhere between $60 and $100 trillion to the global economy. And this data was poo-pooed, but I chivvied the World Bank for a couple of years, and eventually, last autumn, they produced a report, and essentially, they got to much the same figure that the global GDP, if we didn't do something about it, would go down between 1% and 4%. Global trade would drop by about the same amount. Global livestock would drop by about, sorry, it takes longer to come than I thought, drop by about the same amount. And that would throw 28.3 million people across the globe into poverty, as well as, of course, upping the cost of healthcare. So I suppose I should just point out, we do know in this country that when someone gets a drug-resistant infection, it doubles the hospital stay, so it doubles the cost, and it doubles the mortality. So just imagine that. If we don't take action, the World Bank reckons more than 28 million people will go into poverty, and I'm not going to go through all of these things we'll lose because I mentioned them at the beginning: chemotherapy, organ donations, cesarean sections, big operations, treating the infections of diabetes, and much, much more. So where will we end up? Well, here's a picture of children with TB being treated in 1932 with the best possible treatment of their day, fresh air and sunshine, with a mortality rate of 50%. So I'm actually rather worried if we don't win this fight against drug-resistant infections, we're going to be back to fresh air, sunshine, and hygiene. Of course, part of winning the fight is hygiene, is sanitation and vaccines, very important. But we are going to we're risking losing modern miracles that I've been talking about. And look how it can happen. So this little girl in the 40s bit the inside of her cheek 6 days before these photos were taken, had a temperature of 40 degrees, and she was having difficulty breathing. She was actually one of the first patients treated with penicillin. And what you see is her recovery over a period of 9 to 10 days. So that's what it would be like. Now, the question you've probably all been asking is, so why don't we just make some more antibiotics? And the answer is that we have a problem with antibiotics. Here you see that we've had no new class of antibiotics discovered and come into clinical practice since the late 80s. So essentially, we've got market failure. You have to think about why we've got market failure. We've got market failure because everyone takes antibiotics for granted. We pay very little for them. We really do. I mean, they're rarely into treble figures, they're double figures. So we pay very little for them, we treat them with disregard, and they're really difficult to make, to find. And the whole world had disinvested in microbiologists and basic scientists who look at how bugs work and therefore could find new ways of antibiotics. And most of the pharmaceutical companies have disinvested because there's no money to be made. Quite early on in this, I went to see one of our big drug companies, and he said, well, Sally, yes, we will need new antibiotics, but I'm leaving that for other companies. We're going to make a lot of money through cancer treatments. And I pointed out I thought he had a social responsibility, but that actually, as I explained to you at the beginning, would we want to buy the cancer drugs if we couldn't be treated for it? And so if I show you from the O'Neill report, Jim's report, there are some drugs now in the pipeline, but one of the problems is that the nasty bacteria at the moment are called gram-negative. They have 2-cell walls. So you've got to get the drug in through 2 walls, and there are pumps that are busy pushing it out and other things destroying it. And the successful antibiotics we have are not synthetic small molecules like most modern drugs. We have either small molecules or biologics, which are big and complex and biological and made in fermenters. They're natural products that came from nature that are quite big molecules and work in multiple ways on the bacteria. So they're complex. The low-hanging fruit, as the expression goes, have been found, and we had, as a world, disinvested. So it's actually particularly worrying when you think about how long it takes to find a drug, make it, get it through regulation and market it. And it takes, on average, about 20, 25 years. So if you thought, as I was showing you this data, well, there's plenty of time. No, not for our children, because if they haven't got it in the pipeline now, at the beginning, we're talking about 20, 25 years away. We have a business model that's broken. And clearly, we have to address this globally, and we are beginning to. And we've compounded this, not only by all the things I've told you about, but actually by the fact that infections don't respect borders. So what I'm showing you here is some work from a mathematical colleague in Berlin, and as many actuaries have a mathematical background, I thought you'd be really interested to see what the modelling shows is that we in London, because of Heathrow, are actually, for infections, closer to Hong Kong and JFK than we are to Birmingham and Glasgow. And it's beautiful work and modelling, and I've been over it quite carefully with the researcher. Bugs know no borders. So we cannot say it's not a problem for us. It is a problem for us wherever anyone is misusing and doing it badly. So what do we need to do? We've got to use the antibiotics we've got much more wisely. We need to make sure that people who haven't got antibiotics get them. That is the access issue. We've got to do good infection prevention. Did you know that when you've been to the lavatory, you should wash your hands with soap and water, and you should sing happy birthday twice? No. It takes an abominable long time. I did the Friday evening lecture at the Royal Institution, and we got permission to have a colleague and the ladies and the gents to see how many people wash their hands properly. Because after all, they were coming to a science talk. We thought they'd be science aware. I have to say, the results were abysmal. I knew I was being watched, so in my mind, I sang happy birthday. But it does take a long time. We need to understand the interaction between humans, animals, and wider environmental aspects. So you get the agriculture and the vets saying, but where's the evidence that our use impacts on humans and kills humans? And actually, there's very limited evidence because people haven't looked. But my argument is, we haven't looked, but do we really want our environment contaminating with overuse? Because that can't be good. And the whole story reminds me of a book that the older people in the audience will remember with me. Rachel Carson's Silent Spring. Did any of you read it? How we're slowly poisoning our planet, but actually going up through the food chain, these things become more concentrated. We need better diagnostics, because actually one reason GPs and the public find it difficult knowing when to have them, so we abuse them, is because we don't know whether that throat is a bacterial or a viral infection. For sure, we can make good educated guesses. And we need to work to get this all sorted out. And this means a lot more evidence. And as I said, the evidence was thin when I started. People had disinvested in all of this. I'm pleased to say that's moving on. We've got to have good governance about how all of this works. We need some leadership. One of the things I asked our government to do was to place antimicrobial resistance on our national security risk assessment. It's next door to pandemic flu and terrorism, right up there. When we did the modelling, and you probably all know much more about modelling than I do, it came out like that. We did the Jim O'Neill review. We're raising public awareness. Indeed, in the Northwest at the moment, there is a trial or a pilot of a television ad. What the advertising company found was that we are in such an odd position in this country that people said if their doctor said, I don't think you need an antibiotic, they thought the doctor was trying to save money. So this ad has some antibiotics telling people to save them for when they really needed them. I thought, as I come to an end, it's just worth highlighting Jim O'Neill's 10 recommendations. I kept saying, couldn't he make it 3? But no, he couldn't. And all of them are right. Of course, the massive global public awareness campaign is fascinating because it's got to suit the culture of the country and the system of the country, but we do need to do something. And I think I've gone through most of those. Let me pick out number 5 about surveillance. We had good surveillance. We've improved our surveillance. It's as good as anyone in the world. But across the world, in most countries, they don't know what problem they have and how big it is. So I'm very lucky that Chancellor Osborne gave us a fund of £265 million of official development assistance, ODA, to support low-income countries develop their laboratories and capacity so that they can do that. And clearly, we've got to find a way to sort that market failure, and everyone now agrees that we need what's called delinking, and we need a new market mechanism. We need some incentives, and I probably could talk about that if someone questions me. And I set out to build a global coalition for real action. And as I started to work internationally to build that coalition, I kept coming back to this country saying, you know, I know we've got a strategy across government, working with the vets and everyone, but I do feel a bit exposed internationally if we're not doing really well. And I'm pleased to tell you that I chaired a meeting recently, and we are really turning the corner, reducing our use, being much more careful in this country, as well as developing everything else. We're getting much better data. So we do an annual point prevalence study, that is every patient sample on one day in the country is looked at, and this PHE, Public Health England Fingertips website is wonderful. We can look up how our local GP is doing, and their use and everything. And we're also doing what we ask the whole world to do, a One Health report, which means it's not just humans, it's animals and the food chain as well, what's going on. So we are making good progress, and we're underpinning it with data. We needed to. The Global Coalition has made sure that we increase the amount of research, and this just shows you some of the UK funding from a Research Council initiative, the National Institute for Health Research, and we actually have a funders forum. But I can report that across the world, more and more people are putting money in. So BARDA in the US is spending $250 million on new drugs and innovations. The Innovative Medicines Initiative from the EU is spending $700 million. And we're going to have to do things differently and be innovative. So I went on holiday. And one reason I went to Flores, which is an island down from Bali, it goes Bali, Lombok, Flores, is because they have the Komodo dragons. I've wanted to see them all my life because these are the ones that are the biggest lizards in the world. They grow to 3.5 meters. But the reason I'm particularly fascinated at the moment is because they kill their prey by just biting them and leaving them to die of untreatable infections. Then they go back and gobble them up in 17 minutes. Then they don't need to feed for 19 days. It's revolting. And they are quite horrid. And I kept saying to people, so what is it that they've got that allows them to live with bugs that when people are bitten and taken off to hospital, they're not treatable? And blow me, some Americans went and took some blood, and they found 16 new peptides. 48 novel potential peptides. They're a totally new class. They've evaluated 8 of them, and all 8 worked and killed some really nasty infections, and so they're really looking into those. I went to a meeting and I discovered a German group working on beetles, because beetles live in the soil. Piles of bugs there, and yet they don't die of infection. So we have got some people being innovative, looking in interesting places. And we need to take that data into policy. So I told you about NDM1 and China, MCR1 and colistin in China. So the advantage of a benevolent dictatorship such as China is that when they realized what was happening in 2015, then in July, summer 2016, they just banned colistin. And they've taken out more than 8,000 tons of colistin as a growth promoter in a year. And that means that they're maybe using other antibiotics or Chinese traditional medicines, but at least they've stopped the colistin. So it can be done. It's not so easy in our environments, but there we are. Now, as I finish, I want to highlight the international work we've all been doing, because Britain has played a massive leadership role in this, and we have to, because when we started on this journey, I published my report in 2013, nothing much was happening. And it is clear, I hope you can see from what I've said, that we can't just be in an island and close our boundaries, that we have to work globally. So there had been a couple of actions and efforts, but they hadn't got very far. So we decided, I published in 2013, we'd get a World Health Organization Assembly resolution, and that would lead through to the following year to an action plan for the whole world. And actually, we got 194 countries to sign up to that action plan, to take it through the Food and Agriculture Organization and the Organization for Animal Health. So we got everyone signed up to a global action plan, and then we took it to, and the whole issue, to the UN General Assembly last September, and then next week, we have the first meeting of a coordination group to which I'm invited as convener, set up by the new Secretary General of the UN to try and take the global work forward and help make sure there is support for poor countries to make the changes that are needed and chivvy the pharmaceutical industry into producing new drugs and the medical devices industry into making some rapid diagnostics, because it's only by doing all of this that we will save our children and grandchildren. Thank you.
Well, Dame Sally, thank you so much for that fascinating talk. Some frightening and some encouraging information there, I think, for us. We do have some time for questions, and it's a sign of just how interesting I think this topic is, that we've had already far more questions on Twitter than we've ever had for one of these lectures before. So I'm going to start just by asking one of those questions and then throw it open to the floor for others. And this is probably a real killer to start, so I'll give you the hard version and then the not quite so hard version, which were 2 questions that came in. One, thinking as actuaries, the question is, how can we model the potential range of impacts and outcomes here, given all the uncertainties about how fast the spread is happening, about how some of the mitigations might happen, and the new treatments that might come on track. How can we model the potential range of impacts here? And the slightly simpler version is, what do you think the worst case scenario on global mortality might actually be?
Thank you. Yes, I was going to say, I thought you lot were better modelers than I am, but we do have good modelers working on this, not only here in the UK, but in World Bank and everything. So we see that as the worst case scenario as the work that the O'Neill Review did, the 10 million deaths every year by 2050 if we don't sort it, which was mirrored by the World Bank. So you get people who look at those and they say, no, it can't be that big. And then off goes World Bank and has its own go with its own basic work and modelling and comes up with a very similar figure. So I think the worst case scenario is horrendous, but we're making progress and I sincerely hope we never end up there. But we didn't go for that figure to shock people. We set out to work out, based on what we know now and modelling it, where will we end up, and that's where we ended up.
And can I ask, is there anything in the modelling that's done that would indicate, how, what the range of possible outcomes around that might be? Well.
There is, and so for the financial modelling, I did mention a range of trillions of pounds that it could be of the GDP. So there is in that work. I'd have to go back and see what the actual figures were. Yeah.
Okay.
But I would also point out it's likely to be worse than that because they only looked at 4 of the concerning drug-bug combinations of the WHO. And the WHO had, at that time, 7 of concern and now 9 of concern. And they didn't even bother to do the others and add them in.
Okay. Thank you very much. So I'm now going to ask for questions from the room. Can I remind you, please, there are roving microphones. If you could wait for a microphone when you do have a question so that people can hear what you have to say, and also be helpful if you could state your name before asking that question. I have the first one up on the right here.
Thank you, Dame Sally Davies. That was a very fascinating overview. I'm Nicola Oliver, and I'm actually sitting on the working party on the FIA for antibiotic resistance. So we're looking into some of the outputs that might come as a result of modelling. My question really is about mitigation. And you covered, obviously, the main points around good stewardship and public understanding. And one of the areas that was raised in the O'Neill report, which I wondered if you'd had any more thoughts on whether or not we were going to see any kind of policy change, and that's really around the purchase and distribution system of antibiotics to help stimulate drug development, because as you quite rightly pointed out, the remunerative return for pharmaceutical companies is much poorer than, say, a chronic disease drug.
So I do think we're beginning to get some traction on the need for a new model. The Innovative Medicines Initiative of EU has funded a big programme called Drive AB. They've come up with a very similar model, though it's not yet public, to the O'Neill one of delinkage and push and pull incentives. Boston Consulting Group have done a background paper for the German presidency of G20. Also said we need a delinked model, also come up with it'll cost about $1 billion per antibiotic and per year type of thing. And we're waiting for July when the actual G20 heads of government meeting is for an OECD paper, but the work with them suggests they're going to come up with much the same. Meanwhile, the World Economic Forum have said that they will work with a few countries and drug companies to see if they can pilot some experiments of this kind of delinkage and the stewardship that needs to go with it. So when we talk about stewardship, what we mean is that the drug will be used appropriately. So if you think about the market failure, it's even more complex than I explained. It's not just that it's cheap. Most people, well, companies earn their money by selling the drug for the patent life. And the more they can sell, the bigger the profit. And they quite like selling things that you will take every day, like high blood pressure tablets or diabetes ones. A couple of problems with antibiotics. One, you don't take them every day. With a bit of luck, you won't even have a week in a year. You take them short, sharp. So that doesn't make lots of money. The other is, of course, the more you use them, the more resistance will happen. And you could end up with resistance before the end of the patent. So you don't even get the patent life to make money, even if we could raise the price of them, which presumably we could. So we need to have a model where the R&D is paid for and the drugs are available, but actually I can, as Chief Medical Officer, lock them up in a cupboard and only let them out when they're really life-saving. That doesn't make for much money. So we need, well, looking at models like Gordon Brown developed for vaccines, pre-advancement commitments and things like that. So it's a very complex area of modelling. I'm glad I'm not in charge of it, because I'm not an economist, but there is now quite a bit of work going on, I'm pleased to say. But we also need to get vaccines, more vaccines for other types of fish than salmon and trout. We need vaccines for animals, different growth promotions.
Thank you. And at the front here, please.
Hi there, thank you very much. My name's Charlotte Nolan. I'm particularly interested in this because I've actually gone part-time as an actuary and I'm doing a biomedical sciences degree with a particular interest in microbiology. My question relates to, as well as trying to develop new antibiotics, how much progress is there in using bacteria to fight bacteria and viruses as well to fight bacteria?
So bacteriophages are a type of virus that infect bacteria and kill them. They look quite hopeful. The Russians used to use a lot of those, and there are a couple of spin-out companies in Leicester developing them. So I used to talk about my expectation that when I went in for a hip operation, instead of having antibiotics, I'd drink a soup of a lot of different phage because they're very specific to the type of bacteria. It's not just the strain, it's the very subtype. So it may come to pass, but I met the Russian who's in charge of antimicrobial resistance for the Russian Federation, and he was very glum about bacteriophage. He didn't think it would pay off. So I don't know whether it'll work. But we're going to have to try all sorts of different methods. But it is interesting, as I learn more about this, I discover that most people's nasty infections, whether post-op, well, post-op may have gone in through the operation, actually, but with leukemias or cancers or just a debilitated old person, they get that infection from their own guts. So if we can keep the gut microbiome, flora, healthy and clean, that's another way of approaching it.
Thank you. And a question at the back, please.
Hi, I'm Claire Richards and I'm here from a responsible investment organisation, Share Action. Over the course of the past year, we've been working with the FAIR initiative to coordinate a large investor group to try and encourage fast food companies, restaurants to introduce more stringent policies on prophylactic use. So obviously, as you know, that's using antibiotics to prevent rather than to treat sickness. And what we've been finding is there are signs of progress, and one would hope so, because that investor group has 70 members now and more than $2 trillion of assets under management. But companies are tending to make small steps, obviously still positive, but just limited to poultry and just in their US market. There's very much a tendency that they're kind of doing it where the civil society pressure and the media attention is more, and stopping there. And my question really is, what more can be done? You know, the stats that you're presenting and that have been shown down the years are shocking. It's an apocalyptic scenario, and yet food companies just aren't really stepping up sufficiently to take responsibility for what they can do to mitigate this risk.
Let me start by saying thank you to FAIR. I know about your work and I applaud it. And I think we have yet to wake up the consumers in this country as much as in the States, and the investors, and you're starting that. I think it's going to be a long haul because clearly no government wants to regulate and then find that people are cheating. So it's a quite difficult one. I am told by the chief vet, we are co-chairing a meeting tomorrow with a lot of people from the agriculture sector, that just as in humans, we're beginning to make a bit of steady progress, but this is a long, slow haul, and it's a difficult one to regulate for, even were a government inclined to regulate. So consumer pressure, investor pressure becomes more and more important.
I'm afraid we are running out of time, but we might have time just for one more question. If there's from the floor, again from the middle of the room, please.
Martha Henriquez, I'm a science reporter at the International Business Times. I was really interested in what you said about there being no sort of code you can put on a death certificate to really start appreciating the scale of the problem. Do you also think the fact that people who are older, immunocompromised, perhaps vulnerable in some way, are the most likely to have this kind of infection? Is that a problem as well in terms of understanding it?
Yes, absolutely. You're bang on. They're more likely to get an infection, and if it's a resistant one, they won't throw it off as well as someone who was young and healthy who by chance got a resistant one. Yeah. And our modelling of those 5,000 deaths happening a year in England at the moment are E. coli generally and old ladies in care homes. Yeah.
Yeah. I'm afraid we will have to draw things to a close there. Dame Sally, thank you so much for that. I think I'm particularly struck by a lot of the similarities with the whole climate change debate and the issues that are being established there. It sounds as though you've got many of the same issues around sort of engagement of the public and internationally, but maybe you've got a bit further with international governmental cooperation than the climate debate, but a long way to go nonetheless. I think I would just like to remind people or encourage you, or those in the room and those who've joined on the feed, to take the time to complete the feedback survey, which you will be sent tomorrow. This obviously will help us to make sure that we are arranging these events as well as we can for the future. And I will invite you in a moment to join me and Dame Sally for drinks in the foyer afterwards. But before we do that, thank you to all of you who have participated this evening here at the Royal College of Physicians. Thank you also to those who participated so actively through the Twitter feed that we had. And of course, thank you so much, Dame Sally, for such an interesting presentation.